and he's a dear friend of mine. He's the director at the Gujarat Endocrine Center, Ahmedabad, for the past 23 years. He's been awarded one of the most inspiring endocrinologists of India by Economic Times in 2020. He was the organizing secretary at the ESICON 2015, where I was also one of the faculties. He has been a very close and a dear friend of mine, and we were together at the IDF conference in Paris. We have very good and close associations and memories. Over to Parag Shah, please, for your talk on allogliptin.
Can I share my screen, please? Good afternoon, everyone. Thank you, Dr. Raghu, for nice words. Thank you, Dr. Bansi, for this excellent scientific extravaganza. What I will be discussing is, again, one more gliptin, but I feel that this is the least discussed gliptin among all the gliptins, which is available in India, which is CVOT safe. It is the only CVOT trial proven gliptin available at a generic rate in India, that is allogliptin. We all know that the number of diabetic patients globally and specifically in the Asian subcontinent is significantly increasing. Unfortunately, we are going to have more than 134 million patients within next 1.5 decades or so. And we all know DPP-4 inhibitors very well. We can use this as a monotherapy, as an add-on therapy. And most of the DPP-4 inhibitors which are studied for CVOT has been found to be cardiac neutral, except SEXA had a doubt about the worsening of the heart failure. And Indian patients, there is enough data in our own experience also showing that probably we are responding better to gliptins compared to Caucasian populations, probably because of the high carbohydrate ingestion, which is stimulating the GLP-1 better in us. So we got a 4 patented gliptin with a cardiovascular outcome data available with us, like sitagliptin, Sexa, Lina, and allogliptin. Allogliptin was the last one to get approved in 2013, and India it got approved in August 2014. Allogliptin is patented by Takeda, Japan, which was approved in USA 2013. It is a very selective inhibitor of DPP-4 enzymes, and there is a single dose administration can lead to peak within 2 to 3 hours post dose, and it exhibited more than 14,000-fold DPP-4 selectivity over DPP-8 or DPP-9. So it is one of the most selective DPP-4 inhibitor available with us. US FDA is approved as a single drug, as a standalone, in a combination with metformin, and interestingly in a combination with pioglitazone also, because pioglitazone also was patented by Takeda globally. This is the pharmacokinetics. It's orally available 100%, and half-life is quite long, so it's ideal drug to be given once a day. And if you see the selectivity of Vilda, Sita, Sexa, and Allo is more than 14,000 more selective for DPP-4 compared to DPP-8 or DPP-9 enzyme. So it is more selective. And if you see the side effect profile, we all know that all gliptins are usually very well tolerated. We hardly have to discontinue the gliptin because of intolerability or significant adverse effects. The most common is the nasopharyngitis, URTA, and the headache, which is almost comparable, slightly less, though this is not a head-to-head comparative study, but probably it is one of the safe gliptins available with us. What about the inhibition after 24 hours? You need at least 70% inhibitions to have the proper 24 hours inhibitory actions of the gliptins to be effective. Allogliptin maximum inhibition is 90%, and after the first dose and after 24 hours, there is more than 75% inhibition of the DPP-4 activity. So it's truly once a day gliptin available with us. And if you see the A1C drop is almost comparable, almost 0.6 to 0.8% reduction in the HbA1c is seen with almost all the gliptins. Higher the A1C, more drop would be there of A1C up to 1 to 1.2%. And Indian patients or Asian patients probably has a 0.2 to 0.3% more A1C drop compared to the Caucasian counterparts. What I would be focusing more is the landmark CVOT trial of the allogliptin on a very high risk patients pool. We have to understand this is the first CVOT trial, that is examine trial. And why it was done? We all know that diabetic patients has 2 to 4 times more chance to getting the cardiovascular events compared to non-diabetic populations. And we all know that US FDA had mandated 2008 to have the cardiovascular safety trials, and that is how all these CVOT trials were designed. So objective of examine trial is to determine whether allogliptin is non-inferior to placebo with respect to major cardiovascular event in patient with type 2 diabetes at very high cardiovascular risk. And this is the only cardiovascular long-term outcome trial where the patients enrolled were very high-risk patients with a recent acute coronary syndrome patients were excluded. We will see how actually the trial was designed. And if you see the representation of Indian patient, 20% of this global trial data are from the India. So we got a more than 400 patients cardiovascular outcome trial data available with us in this examine trial. So here patients were given allogliptin versus placebo with standard of care, and patients were follow up. And this is again a, like all CVOT trials, this is a event driven trials. But most important thing we have to remember is that apart from type 2 diabetic patients who are not on gliptin or the GLP-1 analog therapy, patients should have acute coronary syndrome within 15 to 90 days before randomization. So these are the recent onset acute coronary syndrome patients with a glycosylated hemoglobin ranging from 6.5 to 11%, and exclusion criteria are all standard except unstable cardiac disorder patients like NYHA class 4, refractory angina, uncontrolled arrhythmias, critical valvular heart disease, severe uncontrolled hypertension. Most of the trials would exclude unstable patients in any CVOT trials and dialysis within 14 days before the screening. So out of around 5,400 patients, around 20% discontinued either because of the adverse reactions, both in the both the arms, placebo as well as the allogliptin arm. These are standard. Usually 15 to 20% patients don't complete the study because of the various reasons, including meeting the unfortunate criteria of death. So primary endpoint was death from the cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke. That is the primary endpoints. The secondary safety endpoint, apart from these three, there was a data analysis planned to for the addition of urgent revascularization due to unstable angina within 24 hours after hospital admissions. Exploratory endpoints, which is a surrogate endpoints, I would say, included death from the cardiovascular cause or death from any other cause, and any other safety concerns, specifically hypoglycemia, angioedema, pancreatic cancers, and any other lab abnormality which is of clinical significance. So if you see the allogliptin versus standard care arm, the primary MACE endpoint is similar. Cardiovascular death also is similar. Non-fatal MI, non-fatal stroke, and if you include the need of urgent revascularization, then also allo versus standard care did not show any significant difference. You can see the hazard ratio is quite neutral. A1C reduction is slightly better with the allogliptin compared to standard care arm, and the fasting blood sugar reduction also was slightly better, but it was not a primary aim of the study. This is the cardiovascular outcome trial. And if you see, if you capture all the events which is more than 3% of adverse reactions in allogliptin versus the placebo group, here again there is no signals except cardiac failure congestive is slightly more. We'll discuss about it later on. Cardiac failure alone is not difference, and rest all the cardiac events or other safety signals did not differ much. So statistically there was not much difference as far as the adverse reaction is concerned. So it met the endpoint of cardiovascular safety or non-inferiority to the standard care arm, composite of CV death, non-fatal AMI, non-fatal stroke, unstable angina, or revascularization, you can see the hazard ratio is 0.98. If you see the cardiovascular hospitalization for any reason, again it is neutral, and need of coronary revascularization also is neutral, allogliptin versus the standard care arm. So it proved it cardiovascular safety or neutrality compared to standard of care treatment for diabetes. So in a background of the patient who had a recent acute coronary syndrome. So in a relatively high risk population also it found to be cardiovascular safe or the neutral. And if you compare the severity examine TICOS and Carmelina study, all studies are gliptin based CVOT trials, and examine study is the only trial where they took the patient within 15 to 19 days prior to randomizations must be having acute coronary syndrome, and all showed a primary endpoints which is showing cardiovascular neutrality. Hospitalization for heart failure was significantly more with severity, and we'll discuss about the examine and what is the real understanding or the interpretation of the hospitalized for heart failure and the risk of allogliptin is there or not. So we reevaluate the examine for hospitalized for heart failure. Actually, it was not a primary or secondary endpoint to see the hospitalization for heart failure. You can see the study design was not there, but because the saver team showed a signal for in hospital heart failure rate is more with the SEXA compared to standard care. So this patient's data in allogliptin CVOT trial, that is examine trial, also was extrapolatory extended MACE endpoint was seen in 433 patients assigned to allogliptin versus placebo. So 16% versus 16.5%. If you see the hospital admission for heart failure, which was the first event in 3.1% patient taking allogliptin compared to 2.9% taking the placebo with hazard ratio of 1.07. So it did not show any significant increase in hospitalization as a first event for allogliptin versus the placebo. So in a patient with type 2 diabetes and recent acute coronary syndrome, allogliptin did not increase the risk of heart failure outcomes. And if you see the further analysis of the examine study and heart failure, in addition, allogliptin showed no effect on the post-hoc composite of cardiovascular death and hospital for heart failure. This is the usual endpoint in all SGLT2 trials where they composite the CV deaths and hospital for heart failure. And if you see, there is no difference between if you combine both together and if you have the CV death alone, then it's 3.5% for the LO versus 4.5, and hospital for heart failure 3.9 versus 3.3. So slightly more in for the allogliptin compared to standard care. But if you see the sub-analysis more carefully, cardiovascular outcome inclusive of hospital for heart failure but not increase with allogliptin compared with the placebo, including if you take the patient with a history of heart failure and or with elevated NT-proBNP. So if you take the sub-analysis of the sub-analysis of pre-existing heart failure with elevated NT-proBNP, that also it did not show any significant increase in the NP and use of diuretics, which is again the patients were followed up subsequently, and if the heart failure is worsening because of the allogliptin, the need of diuretics would be increased in allogliptin arm, or NT-proBNP would not be decreasing, rather it would be increasing. So reduction in NT-proBNP was similar compared to placebo, and use of diuretics also was similar. So again showing that it did not really increase even in the patients with acute coronary syndrome with a background of high NT-proBNP and history of heart failure to start with. So this is the 2021 ADA professional practice guidelines, again showing that if somebody has no ASCVD or ASCVD, you have to decide, and among the ASCVD, SGLT2 inhibitor GLP-1 is the preferred. But if the target is not achieved, then you have to take the cardiovascular safe drug. If the patient has a ASCVD on SGLT2 or GLP-1 not able to achieve the target, then the cardiovascular safe studied drugs like gliptins can be started. Or if somebody has no ASCVD or heart failure or renal insufficiency, then you have lots of option, and gliptins is one of the good options available with us. So allogliptin showed a cardiovascular safety. So allogliptin is the US FDA approved highly selective cardiosafe gliptin, now available in India at affordable price with a OD convenience. So if you compare allogliptin,
Sir, request you to wrap up, sir.
Yes, it will take 2 minutes. Yes. If you compare the allogliptin with other gliptins, in the mild, moderate, and severe renal insufficiency or hepatic insufficiency, it is found to be safe, cardiovascular safe, and low cost, once a day dosage. What about the renal insufficiency and allogliptin? Up to eGFR of 60, you give the full dose of 25 mg, 30 to 60, 12.5 mg, 15 to 30, 6.25 mg, and it is approved with eGFR of less than 15 or even on the patient on a dialysis up to 6.25 mg. So even with the severe renal insufficiency, you can give with a reduced dose of allogliptin. There is no black box warning for allogliptin for heart failure. So pregnancy, geriatrics, and lactation, it is not to be used. And we got a brand name in India, which is found to be bioequivalence to the innovator brand. So summarizing my talk of allogliptin, highly specific, optimum A1C reduction, no risk of hypoglycemia, cardiovascular safe, safe in mild, moderate, and even severe renal insufficiency patient, including patients on dialysis, mild to moderate hepatic impaired patients, affordable, and FDA guidelines, ADA guidelines also 2020 mentioned, except saxagliptin, it can be considered in patient with history of heart failure. Thank you very much for your patience hearing.